3 minutes. Good day to all the audience who are following our broadcast at the 2021 IWENC. We have the honor today of having Dr. Khoi Tan. Dr. Tan is an associate professor of neurosurgery at Duke University and the Duke Raleigh Hospital. Today, Professor Khoi is going to share with us his lecture, Minimally Invasive Anterior Column Realignment for Adult Spinal Deformity. Please remember to type your questions in the Q&A section down on the bottom part of your Zoom screen. These questions will be referred to Dr. Khoi for at the end of the lecture. So, Dr. Khoi, welcome, and please, the screen is all yours.
Great, thanks so much, Dr. Torres, and thanks to you and the IWBNC team for inviting me to speak again this year. I can't believe it's been a year since last year's talk, which I enjoyed very much, and I greatly appreciate the opportunity to come back. Last year I spoke about my research on peak inner body cages and why I feel that they should not be used in the cervical spine. And I'm going to change it up this year and talk about a technique in spinal surgery that's really interesting to me, specifically minimally invasive anterior column realignment for adult spinal deformity. So these are my disclosures. A couple of things, the company that I do most of my ACR work, I do not have any conflicts of interest with. In addition, I've actually not done any or written any papers on anterior column release, but every single case that I show you will be my own. Like I mentioned, I really enjoy this technique. I've done quite a number now, and I'll be interested to chat with you all about both my as well as your experience with this procedure. So over the next 40 or 50 minutes or so, we'll talk about the history of lateral techniques. I'll show a couple of technical videos that describe how to do an ACR. We'll do a very thorough evidential review of ACR. We'll talk about literally almost every paper that's been published. Fortunately, it's not that many papers. And then we'll go over a couple of cases that highlight some of the controversies with ACR that I hope will stimulate some discussion from you, Dr. Torres, and the audience who's so kind to join us today. So first of all, the history of lateral techniques. I think lateral spine surgery has really revolutionized minimally invasive spine surgery. It was first described by Dr. Luis Pimenta of Brazil in the 1990s, and goes by a number of different monikers. One is XLIF, or extreme lumbar interbody fusion. That's if you're using invasive, whereas direct lumbar interbody fusion is the acronym if you're using Medtronic. They describe absolutely the same thing. The more formal name would be minimally invasive lateral retroperitoneal transpose approach. And increasingly, people, including myself, are doing minimally invasive retroperitoneal prone transpose approach. So lateral approach surgery with the patient completely in the prone position. Now, as neurosurgeons, we give a lot of attention to the brachial plexus, right? So anytime you have a written exam or an oral board exam, you're studying the brachial plexus. 99% of us probably forget about the brachial plexus as soon as the exam is over. But I think with the rise in popularity of lateral lumbar surgery, it's so important to understand the lumbar plexus. In fact, I would argue that the lumbar plexus, because of the popularity of lateral lumbar surgery, is probably more important for a neurosurgeon to know than the brachial plexus. So just to go over these branches, this is the genitofemoral nerve, the ilioinguinal and the iliohypogastric nerves. That big one's the femoral nerve. That's the obturator nerve, and that's the lateral femoral cutaneous nerve. And these provide a number of very important functions. So the iliohypogastric, the ilioinguinal, and the genitofemoral nerves all provide sensation to the buttock and groin region, while the lateral femoral cutaneous nerve provides sensation to the anterolateral thigh. And people with neuralgia paresthetica have compression of the LFCN. Now, really important to understand are the motor branches of the lumbar plexus, which are the obturator nerve, which comes from L2 to L4. These provide motor strength to the adductor muscles of the leg, whereas the femoral nerve, the biggest branch of the lumbar plexus, also comes from L2 to L4 and provides motor function to hip flexors and the quadriceps. And there's a lumbosacral trunk that descends to join the sacral plexus. Really the key to lateral approach surgery, whether it's straightforward lateral interbody surgery or whether it's anterior column release surgery, is neuromonitoring and patient positioning. Neuromonitoring because we really want to monitor all of these nerves, particularly the motor nerves to the important leg muscles that we've talked about, and as well as patient positioning. It's so important that the patient is resting on the table in such a manner where you get true AP and lateral images to the spine. So generally, this is a picture from a chapter that I wrote during my residency, but a couple of things here. You can see the patient securely taped to the table in order to get true AP images to the spine so that the spinous processes are lined up perfectly in the middle. And you get crisp views of the pedicle. You'll need to airplane the patient back and forth. And then in order to get crisp images of the disc space, you can then Trendelenburg or reverse Trendelenburg for each level of interest. A couple things here. You'll see that we've introduced a large break into the table. I bet that most people aren't breaking the table to this extent anymore, just due to concern for stretch injuries to the psoas. But oftentimes, especially at L4, L5, I'll break the table a little bit just to get the iliac crest out of the way. With the popularity of lateral spine surgery, it begs the question, how much correction can be accomplished with with these techniques? So before we get to that, it's important to discuss a couple of important definitions here. First, the SVA is also called, stands for the sagittal vertical axis. This is measured by dropping a straight line from C7 down to the ground and measuring the distance of this line to the posterior superior aspect of the sacral end plate, and the distance from your C7 plumb line to the posterior aspect of the sacral end plate is your SVA. And generally, this value should be less than 5 centimeters, although as we get older, there are more age-appropriate parameters. But generally, even as you approach more elderly ages, 6-7 centimeters is fine, but usually not much above that. Pelvic incidence is a fixed parameter. This is measured by finding the midpoint of the femoral heads, drawing a line from here to the midpoint of the sacrum, and then the angle between that line and a line perpendicular to the sacral end plate is your pelvic incidence. Generally, this is between 45 and 55 degrees. The pelvic tilt would be similar, but instead of a line perpendicular to the sacral end plate, it's a line straight down. Generally, that value should be less than 25 degrees. With increasing pelvic tilt, it suggests increased pelvic retroversion as patients compensate for flat back and try to get their SVA into a normal realm. Lumbar lordosis I generally measure as the angle between the superior end plate of L1 and the superior end plate of S1. So that's pretty straightforward. And we know that that number needs to be within 10 degrees of your pelvic incidence. So when we think about open procedures to help restore sagittal deformity, generally these are broken into the 6 Schwab osteotomies, which are illustrated in this video here. So a Schwab grade 1 osteotomy is essentially the resection of the inferior facets of a given level with posterior compression. That can give you about 5 degrees of correction. A grade 2 is removal of the inferior facet as well as the superior facets. That's more commonly known as a Smith-Peterson or a Ponti osteotomy, which will give you about 10 degrees of a correction. A grade 3 is more commonly known as a pedicle subtraction osteotomy. So here you remove the superior and inferior facets and then cut a wedge into a vertebral body. The compression across that can get you about 25 degrees. Grade 4 osteotomy is essentially a PSO plus a discectomy. This supplemented with some inner body fixation can get you about 35 degrees of correction. Grade 5 osteotomy is more commonly known as a vertebral column resection. So this involves complete removal of a vertebral body, the adjacent disc spaces. You're essentially completely disconnecting the spine here. Because you're disconnecting the spine, you can get about 40 degrees of correction here. And with a grade 6, that's essentially multiple VCRs. Fortunately, pretty uncommon. I've had to do just a few of these, but here you're removing more than one vertebral body and getting pretty significant correction of the spine. Excuse me. So that's open techniques. Now, there's a body of literature that talks about how much correction can be accomplished with straightforward a lateral surgery without anterior column release. The first one was probably written here by Neil Anand and his group at Cedars-Sinai, which found that with a lateral lumbar interbody fusion plus with or without axial lift, which is essentially a transsacral screw, which I don't believe anyone does anymore because of the gruesome complications that were associated with it. But you can see here the average amount of SVA correction was about 3 centimeters, really not very much. You do, because of the lateral surgery, get significant correction of the coronal cob angle. But again, you see with the lumbar lordosis, only about 4 degrees. So essentially the equivalent of, grade 1 osteotomy. Then the ISSG, which is a group that I'm now very fortunate to be a part of, published their series comparing circumferential MIS surgery versus hybrid surgery, just so that you all understand the difference between circumferential MIS and hybrid. CMIS surgery is pure MIS surgery. So MIS TLIF plus minus lateral lumbar interbody surgery with percutaneous pedicle screws. Whereas hybrid surgery was used to describe lateral interbody surgery with open pedicle screws, usually supplemented with open osteotomy techniques. We've trended towards really considering hybrid surgery to not be minimally invasive surgery anymore because you're opening the posterior columns, the posterior soft tissue planes of the spine, and removing enough bone to get your correction. But you'll see here that with circumferential MIS surgery, you're getting a good coronal deformity correction of about 10 degrees, but really only about 3 degrees of lumbar lordosis and a couple of centimeters of sagittal vertebral SVA correction. So this is really where the value of anterior column release comes in. I'd like to thank Jacob Godzik and Juan Uribe at the BNI for allowing me to use this video for my own presentation. But here, essentially, the positioning for the ACR is exactly the same as a lateral, minimally invasive lateral surgery. A couple of things here is that you'll see a shim in place. I actually never use a shim because generally I'll approach these by doing a regular lateral interbody disc preparation first, and then translating the retractor more anteriorly to get access to the anterior longitudinal ligament. So that's why I don't use the shim. Here you see a cob introduced through the disc space and through the contralateral annulus. This is a box cutter. Now this here is the ALL blade. So you can slide that in front of the ALL. And here you see a knife sliding along the ALL retractor to cut the ALL. Now, in my experience, I find that oftentimes the ALL will release on its own with sequential upsizing of the trials. And sometimes that'll just lead to a split of the ALL, and that makes it a little bit more straightforward. When that doesn't happen, you do need to cut the ALL yourself, and that involves very meticulous dissection ventral to the ALL first with a pin-filled 4 instrument. Once I get them down halfway, based on the AP shot here, I'll then slide an ALL retractor down and cut the ALL halfway, similar to what you see here. Once the ALL is cut about halfway, you can put in this spreading device. It essentially acts as a jack, and you can really split the rest of the ALL fibers that way. In fact, oftentimes you'll hear a little bit of a snap when the ALL is completely released. And you see here significant restoration of disc height and creation of lordosis. This is another video, again, thanks to Juan and Jacob at the BNI here, but you can see, I want you to really appreciate the size of the disc space first with the box cutter and then the discectomy. Here, the box cutter, again, is going through the contralateral annulus there. This is the jack device that splits it, splits the remaining fibers of the ALL. You can see them spreading here. And once the blood is suctioned, I think you can really appreciate the size of the, how much disc space opening is accomplished with that jacket. Here is a hyperlordotic trial going in place, followed by a hyperlordotic implant. So what does the data tell us about ACR? Well, the very, very first study, and you'll see that the vast majority of these studies come out of really two places. One is the BNI, where Dr. Uribe is, and the other is out of San Diego, where Greg Mundis and Bob Eastlack are. Almost all the ACR papers come out of those two centers. This is the first one, actually out of University of South Florida, where Dr. Uribe was before the BNI. Really just a small series of 4 patients. You can see that their lumbar lordosis on average increased by about 25 degrees. So that's a lot more than just the 3 or 4 degrees that people are getting with regular lateral surgery. And patients had a significant improvement in their visual analog scale and their Oswestry Disability Index. Perhaps the greatest contribution to that paper was this illustration here, where you can see that even just a couple centimeters more anterior to where we usually are working for regular lateral surgery, we have to really be cognizant of a lot more anatomy. So specifically big vessels like the IVC, branches of the lumbar plexus, and even segmental vessels. This is a study out of San Diego, actually a literature review. There's a couple of literature reviews that have been published. This one looked at 12 studies. Across these 12 studies, they found average change in their patient's segmental lordosis was between 10 and 30 degrees, and really about a 20 to 50% complication rate. Another literature review, this one out of Arizona, essentially confirmed those findings, showing that segmental lordosis on average changed about 10 to 35 degrees. And these authors were specifically interested in PJK and found that PJK across their studies and their literature review was affected about 30 to 45% of patients. And we'll talk more about PJK in a few moments. There's a number of important biomechanical studies that allow us to really understand ACR and what sort of fixation is important when you do an ACR surgery. So this first one out of San Diego found that increased cage height, as you can imagine, increases the amount of lordosis that's achieved. And then when you supplement that with a posterior column osteotomy, you really maximize the amount of lordosis that's provided by the cage. And we'll talk more about that as well. This biomechanical study out of Arizona showed that for maximum stability, ACR constructs should contain either fixation into both vertebral bodies with these cages will have an integrated tabs where you can put fixation into the bodies above and below the ACR. If not, then one should definitely use accessory rods, which is supplemental rods in addition to the primary rods. These authors found that the 4-rod constructs provide much less rod strain compared to just fixation into the vertebral bodies through the integrated tabs. This biomechanical study out of Arizona, again, demonstrated the importance of 4-rod constructs with ACRs. These had comparable rod stress reduction compared to PSO 4-rod constructs, and therefore the authors concluded that ACR with 4 rods is an excellent minimally invasive alternative to the more morbid pedicle subtraction osteotomy. And lastly, this biomechanical study out of Italy, I think goes without saying that when you do an ACR, you should have bilateral posterior fixation in addition to the integrated fixation provided by the cage itself. They found that the rod strains with ACR were comparable or higher than what's called a weak PSO construct, so essentially a single rod or double rod PSO constructs, and so advocated for a caution Although I think when you consider that the other biomechanical studies that demonstrated the importance of additional rods, I think that increases the strength of your construct, certainly. It is interesting to compare ACR versus PSO. This is a study written by J.C. Levesque, who was actually my chief resident when I was an intern at Michigan. This is out of Virginia Mason in Seattle. Small series looking at 13 ACR patients compared to 14 PSO patients. What you'll see is that the blood loss with an ACR is about half that with a PSO, with very, very comparable lordosis induction. And this study out of the ISSG corroborated those studies, slightly larger with 17 in both groups. Again, about 2 liters less blood loss with ACR compared to PSO, although greater T1 slope correction with PSO, but better pelvic tilt correction with ACR. Otherwise, very similar radiographic outcomes and complications between the two groups. The issue of blood loss, I think, is an interesting one. I wanted to show this to you. So this is a picture of the canister after a recent ACR that I did, I think actually maybe 1 or 2 weeks ago. You can see that the blood is well below the 100 milliliter line. And in full disclosure, I let my resident do this ACR. So honestly, the amount of blood is a little bit more than I would have had. But this is footage from a PSO that one of my partners shared with me. So you can see, PSO extremely gruesome, very bloody. Hopefully there's other Game of Thrones fans in the audience today. So some studies have showed the radiographic outcomes after ACR. I really liked this study, again, out of both Arizona and San Diego, where they looked at lateral surgery, ACR without posterior column osteotomies, and then ACR with grade 1 and grade 2 posterior column osteotomies. So again, what you'll see is, and again, this is the change in the disc angle, but with lateral alone without ACR, just 3 degrees, very similar to all the studies that we've showed initially. ACR without posterior column osteotomy, about 10 degrees. With grade 1 osteotomy, about 15 degrees. And then with the full Smith-Peterson osteotomy of the inferior and superior facets, about 18 degrees. So a good rule of thumb is that if you do ACR without posterior column osteotomy, you'll get about half the correction that the cage provides you. And if you do it with posterior column osteotomy, you get the full correction of the cage. This is a 2014 study looking at 17 patients. Again, mean lordosis, restoration of about 35 degrees, improvement of the pelvic tilt by almost 10 degrees, but still a high complication rate, about nearly 50% of patients. And again, here, this study out of Italy, about 27 degrees of lordosis restoration in 11 patients with 2 complications, 1 bowel perforation, which if you've ever had one, as I have had one, it's very gruesome. Patients have a very, very long hospital course with those, and another a case of infection. So again, when this group out of San Diego looked at radiographic outcomes with complications, similar things to what I've been saying before. So about 8 degrees of pelvic tilt correction, about 30 degrees of lumbar lordosis correction. I thought this one was interesting because of the occurrence of lower extremity weakness. So you'll see here before surgery, about 30% of patients had leg weakness. This actually increased immediately post-op, but by year 1 and year 2, there was significant decreases in leg weakness. As this audience probably knows, many patients with lateral surgery will have thigh numbness and dysesthesia immediately post-operatively. But in this series, that completely resolved in all patients by year 2. Always important to talk about complications. So this study looked at 31 patients who underwent ACR. The occurrence of major complications as defined by Glassman was about 20%. But when you look at the ACR-related complications, these are going to be very, very similar to the complications that you see with lateral lumbar, regular lateral lumbar surgery without ACR. So about 8 out of 31 patients had a motor deficit postoperatively. 3 out of 31 had a sensory deficit. There was also ileus as well as retroperitoneal hematoma. But at long-term follow-up, you can see that only 1 of those 8 patients had a persistent motor deficit, and 1 patient did have retrograde ejaculation. This study looked specifically at rod fracture. So a multi-center study, Pittsburgh and Arizona and San Diego. So a total of 90 patients. They found that the rate of rod fracture was only about 4%. Now, very interestingly, the rod fracture occurred adjacent to ACR in all cases. So again, this probably reiterates the importance of 4 rod constructs around your ACR. But interestingly, rod fracture was not associated with the amount of focal correction. It was not associated with the type of rod material. It was not associated with the amount of correction that was obtained, nor was it associated with the presence of an interbody at L5S1. What I found very interesting was that the rod fracture was associated with a longer fusion construct. And so that will put into question something that we'll talk about later with one of my cases as to, how long should you go after an ACR surgery. Now, this study looked at another important complication after deformity surgery, specifically that of proximal junctional kyphosis. PJK is defined as the sagittal angle between the upper instrumented vertebra, specifically the inferior end plate of the UIV, and the superior end plate of the UIV plus 2. So if you're doing, for example, a T10 pelvis, it's the sagittal angle between the superior end plate of T8 and the inferior end plate of T10. And if this is more than 10 degrees, then that qualifies as PJK. Now, I think more important than PJK, which is a radiographic diagnosis, is the occurrence of PJF. And that's essentially when PJK becomes symptomatic. So adjacent level fracture, neurological deficit, et cetera, that requires reoperation. So what you see here is that when you have lateral lumbar interbody only, you have 0% PJK and 0% PJF. But with increasing invasiveness, you have increasing values of both PJK and PJF. So here, lateral with ACR, 30% PJK, 11% PJF. And then lateral with ACR and posterior column osteotomy, about 43% PJK and 40% PJF. So very important to think about this and think about your PJK/PJF prevention strategies. And I'll talk a little bit about what my preferred strategy is. So all of these studies resulted in the creation of a classification system written by Dr. Uribe and Dr. Mumaneni at UCSF, who is my fellowship director. So a grade A is an ACR alone without any posterior column release. And on average, like we've talked about, you'll get about half the correction of the cage here. So about 8 degrees or so. A grade 1 would be an ACR with a grade 1 posterior column osteotomy. With that, you'll get about 13 degrees. And a grade 2 is an ACR with a grade 2 osteotomy or Smith-Peterson osteotomy. And with that, you'll get about 25 degrees. They also described a grade 3, grade 4, and a grade 5. They were quick to mention that that's never been described before. So I think some of this is just, making up classifications and drawing pretty pictures for the sake of publication. But you can certainly read more about it in this article if you're interested about those higher grades. So, in the last 10 minutes or so, I'd like to present some of my own cases and talk about some of the controversies that might bring up. So the first question is, can your instrumentation stop short, right? This is a 77-year-old with back pain and bilateral leg pain. Her symptoms were actually mostly leg pain. So 90% leg pain, 10% back pain. She had difficulty with walking, requiring her to be dependent on a walker. Her symptoms were alleviated with heat and ice and exacerbated with standing, walking, and lying down. Pretty benign past medical history. And her past surgical history was notable for an L3 to L5 fusion. She was neurologically intact on examination. So these are her preoperative PA and sagittal full-length films. You can see here her previous L3 to L5 fusion. Her SVA is 14 centimeters. So I think we'd all agree that that's markedly abnormal. Her pelvic tilt's 35, so you can see that she's retroverting her pelvis to try to compensate for her sagittal imbalance. And she has a PILL mismatch of about 24 degrees. You'll recall you want that number to be 10 or less. This is her MRI, which shows essentially a big, caudally migrated disc herniation above her L3 to L5 fusion with severe stenosis at that L2 to L3 level. When you think about this case, what are her options? She's 77. Most of her symptoms are leg pain. One could feasibly consider a decompression surgery with a discectomy. I elected to do an ACR. Of course, it's an ACR talk. And these are her postoperative PA films there. And these are her sagittal films. So you can see here that her SVA improved from 14 centimeters to 3 centimeters. Her pelvic tilt normalized from 35 to 23. And her PILL mismatch also went from 24 to 3. Important lesson here, this patient actually made me very nervous. At the time of surgery, I was not able to get a screw into that bottom tab. At her immediate post-op films, her she did not have a spondylolisthesis between L2 to L3. And her 6-foot-week film, she did. So you can see there's a little bit of a slip there. The way I managed this was actually I just kept her in her brace for another 6 weeks. And at 3 months postoperatively, this was stable. The spondy had not progressed. So I think the combination of one screw with the fixation is holding her steady for now, but it demonstrates the importance of trying to get a screw into both tabs that are built into the cage. But importantly, at 3 months postoperatively, this patient's back pain was gone, and her leg pain was about 80% improved. She was no longer dependent on a walker. The reason I decided to stop short here is mostly because of the appearance of these disc spaces above L2, which look really good. So in an effort to save a little bit of motion and to not violate levels that actually look pretty good here, I decided to stop short. And I think it's worked out for this patient. Just so that you don't all think that's a one-off, also did it for this patient here who had an SVA of 11, improved to 0 postoperatively, a slight improvement in her pelvic tilt, and pretty substantial improvement in her PILL mismatch from 28 to 3. She's also a woman in her 70s, and at 5 months postoperatively, her back pain was 90% improved, and her leg pain was about 100% improved. She was actually very happy with her care and even referred her daughter to me, whom I operated on just this past week. I think another important question with ACR is how high is too high? So we hear a lot in the spinal literature about lumbar lordosis and how it's important to have your lumbar lordosis really maximized between L4 and S1. In fact, some of my colleagues in the ISSG have written a number of papers showing that when it comes to lumbar lordosis, 60 to 65% of it needs to be between L4 and S1. But is that true? And do different rules apply when you're doing spinal lengthening procedures compared to spinal shortening procedures? This is an 81-year-old man. So old guy, 81-year-old man with low back pain. He had low back pain for a few years, but especially increasing over the past year. His symptoms were worsened with standing and walking, and he could not find anything to help his symptoms improve. Pretty benign past medical history. He's 81, but he's a relatively healthy 81. And his past surgery was notable for an L2 to S1 fusion with laminectomies. So these are his PAA and sagittal x-rays before surgery. So he had an SVF 13, again, very abnormal, and a PILL mismatch of about 27. Important to note here is pseudarthrosis at L5 to S1. So those S1 screws are loose, and you can imagine that was probably because no inner body was done here at L5 to S1. So when you think about this case, how would you choose to do this? Maybe no surgery. He's neurologically intact. He's 81. Maybe no surgery. Maybe you just want to address the pseudarthrosis and do a L5 to S1 ALIF, with or without posterior column work. Again, it's an ACR talk, so I elected to perform an ACR here. Here's his PA films. One thing you'll notice here are the addition of sacroiliac dowels in addition to S2AI instrumentation. We've got a pretty good paper coming out of the ISSG that shows that even when you do pelvic bolts or S2AI screws, about a quarter of those will loosen with time. So these bedrock screws perhaps help decrease the occurrence of loosening of your pelvic instrumentation. Another thing you'll notice is my preferred PJK prophylaxis technique, which is the vertebroplasty of the UIV and the UIV +1. I'll tell you, I've had 2 cases of PJF. They were my first 2 cases. I'm in my 6th year of practice. They were my first 2 deformity cases where I did not do any prophylactic technique. Since then, I've done the prophylactic vertebroplasty for every deformity patient, and I've yet to had a patient come back with PJK or PJF. There's a good paper out of Miami that shows their experience with vertebroplasty, which shows that the rate of PGF, like mine, is 0. So that's a plug for cement. Again, I think there's a variety of good techniques out there, whether that's tethering or shorter, smaller screws or contoured rods or what have you. But I think the point is decreasing the stiffness of the construct. So here's his postoperative films. You can see that his SVA went from 13 centimeters to 6 centimeters. I think that's probably reasonable for someone who's 80. Pelvic tilt improved. PILL mismatch reduced to 0. At 6 weeks postoperatively, his pec pain was gone. He was actually crying tears of joy, joy and gratitude. And we actually saw him again this past week for his 3-month visit, still doing well with his back pain gone. So in summary, I think that the minimally invasive anterior column release is a really powerful deformity technique. You're getting correction very similar, if not better, to a pedicle subtraction osteotomy. And I would say fewer complications, especially with blood loss. You can see that since you're not having to remove big wedges from the vertebral body, you're getting a lot less blood loss. The technique, at least the way I do it, is very, very similar to a lateral surgery. The only difference is really that you're using aggressive trials. Oftentimes, the majority of time in my hands, the ALL will split as you go larger and larger in your trial size. And probably only a third of the time do I actually have to cut the ALL, which is obviously a step that you want to be very careful with, but certainly can be done. I think a lot has yet to be learned about anterior column release, including appropriate level selection. Can you do it in the upper lumbar spine? I certainly think so. The extent of instrumentation needed for durable results. Can you stop at your ACR level, or is that too unstable and you need to go higher? I think, again, when you're getting your focal correction at one level and the levels above your ACR all look good, I think that's a good patient to do less surgery on and to save some motion with and to stop short. And we don't know the long-term outcomes yet, at least in large studies. You saw that the largest single center study was maybe 15 or 20 patients. and the biggest multi-center study was 90 patients. So I think we still have a lot to learn here. I'd really like to thank Jacob Godzik, who will soon be a faculty member at the University of Alabama, for again providing me the videos that I've used today. Also, Ethan Srinivasan is one of our med students here at Duke, who helped me edit those videos, as well as helped me provide the Game of Thrones video demonstrating the blood loss with the PSO. I'd like to encourage everyone, hopefully, as the world becomes more and more normal, to join us for our spine section meeting in July in San Diego. And at this point in time, I'd be very, very happy to answer any questions.
Thank you, Dr. Coy, for such an interesting and valuable lecture. I have some questions from the audience. So I'd like to start with the following question. So how have you seen, or how do you feel about the level with the lateral lift when you do the ACR? Does it affect the degree of indirect decompression that you can obtain at that level, the level of the ACR?
Please definitely let me know if I'm not answering the question, but I think with these, you have no choice but to get indirect decompression, right? I think you saw with some of the x-rays that I showed, both my own as well as in the video, that you're getting extreme correction of disc height here. So I think with that comes excellent indirect decompression. Now in my hands, so far at least, I've always supplemented this with posterior column osteotomies to get the full correction of the cage. And so when you're doing that as well, you're essentially creating a super large neural foramen, and generally doing a laminectomy at that level at that level as well, since you're removing both of the facets. So you're getting an excellent central as well as indirect decompression with this technique, I find.
Thank you. The next question is related to the posterior osteotomy. Posterior osteotomies is type 1 and type 2 specifically, and also in some cases type 3 have been described through an MIS retractor. Have you used this combination of an ACR plus a posterior osteotomy type 1 or type 2 through a tubular retractor, and how have things gone with this technique?
That's a great question. Thanks to whoever asked it. So so far, and I've done a fair number of these. I probably do about one every month or two. So not like every day, but a fair number. So far, I've used this exclusively in patients who've had previous surgeries who've been fused into flat back. Okay, so with that, generally have been doing posterior approaches to the spine in order to extend the instrumentation. Now, I do have a patient coming up where I anticipate she's also been fused, but for whatever reason doesn't have any instrumentation present. Where I do anticipate doing minimally invasive posterior column osteotomies. I've done tubular Smith-Peterson osteotomies with regular lateral interbody fusion, and I've certainly found that to be something that's very facile and where you do get a little bit extra correction than without. But it's essentially it's done the same way. So drop a tube down onto the facet, usually between two screw heads, expose, remove the facet complex on one side, both the inferior facet and the superior facet, and then repeat that on the other side. And then you have compression techniques across your screw extension tabs to really maximize your lordosis. So I've not done it yet with ACR, although I think I will soon. But I have done it just for regular MIS surgery. I think both with MIS lateral as well as MIS TLIF, and found it to be pretty straightforward. You get what you're looking for there.
Thank you. The next question is the following. In which cases would you consider the use of cement augmented screws in MIS surgery with ACR?
Great question. I think it really has value. I think certainly if the bone quality is poor, I think there's great evidence now looking at cement augmentation, specifically for osteoporotic patients and patients with cancer, and how cement augmented screws really almost never loosen, right? So I think what I might start doing is any patient where I'm stopping short, when I'm stopping at that ACR level, I might start augmenting that screw. In addition, I'm augmenting the screw whenever I extend constructs into the lower or upper thoracic spine. I'm cementing the top 1 or 2 screws in addition to the UIV plus 1. I think the key really is making sure not to operate on osteoporotic patients. If a patient has osteoporosis or a suspicion of osteoporosis, then I'm having them get bone scans. If they're osteoporotic, I'm sending them to an endocrinologist to get, bone building medication for at least 3 months before surgery. That's teriparatide, or there's also another newer agent out there. But to answer your question, I think when we stop short, I'll probably start augmenting those screws, and then any screws that extend into the thoracic spine, I'll augment the top 1 or 2 screws. But I do that anyway for PJK prevention.
Thank you. The next question. Since this is a very instabilizing surgery, do you think that there may be a role for the use of cobalt chrome rods? Or what would be do you think would be the role of these kinds of rods through an MIS approach?
Certainly. We know that cobalt chrome rods are stronger than titanium. Now, I think we found with that one multi-center study that looked at rod fracture, they actually did not find a difference between using titanium and using cobalt chrome. But to your point, I think that because it is unstable and you want a very, very strong construct, that it's not unreasonable to use cobalt chrome. I think we're still learning a lot about the science of rod selection. I think in some patients, cobalt chrome is too stiff. In some patients, cobalt chrome is exactly what you need. I find myself using cobalt chrome more often in sort of patients, where the screw fixation is really good. They very, very clearly have, a very strong bone, generally sort of, younger, more big boned males. Whereas in sort of older females, I'm resulting more, and where the bone's softer, I'm resorting more to using titanium. It's really a gestalt thing, and I think there's a lot to learn about the science behind that. And I think one great study might be to compare, to do a biomechanical study looking at ACR and specific rod types. I do not believe that that's been done yet.
Thank you. The next question is with respect to spinal fusion. Most reports on lateral surgery show pretty good fusion in the short and long term. What do you think is the role of BMP, and do you use it often? And if you do, when do you use it?
That's great. So, it's important first to point out that BMP is only FDA indicated for single level anterior surgery. So 1 level ALIF or 1 level lateral surgery. That being said, the vast majority of surgeons, I feel, most likely, as well as myself, don't use BMP in that situation. I think there's other biologics out there that are perhaps less expensive, have less of a notorious complication profile that I've had success with. I use BMP mostly mostly posteriorly for big cervical thoracic or thoracolumbar deformity surgery. So these cases here where I've, for example, that 81-year-old man where I went, T10 to pelvis, I certainly used BMP for that case, certainly posteriorly. And that's when I'm mostly using BMP. I think BMP is very, very reasonable to use for ALIF and for lateral surgery and for ACR, your cage. I just don't happen to use it in my inner bodies because I've had success with a different type of biologic.
Great, thank you. Now a few technical questions. With respect to the technique of ACR release, what technical recommendations would you give those surgeons who want to start to do this kind of surgery?
Yeah, so a few things. Be patient. I hear people brag about 7-minute retractor times, and that's not the goal here. Your goal is to be safe and not injure the bowel and not injure a vessel, which would be absolutely devastating, right? So, like I mentioned, I typically start by just doing a regular standard XLIF, beginning to end. So Cobb, curettes, ring curettes, rasps, okay, thorough discectomy, make sure you're through the contralateral annulus. Then I'll start to slowly dial up with the trials. So regardless of how big the disc space looks, I start with the skinniest trial. I think it's a 4 millimeter trial. Go through, make sure I'm through the contralateral annulus. I think the more you release the contralateral annulus, the more coronal deformity correction you get, and I think it may contribute to making your ACR a little easier as well. So then I'll go up to the standard, 10-degree trials, go up and up. And then it usually gets pretty snug, okay? Sometimes it doesn't. Sometimes the bones just continue to open, and then I'll just go up to the 15-degree trials, okay? Keep going, increasing in lordosis, increasing height. Then a 20-degree trial. Now, if it's very obvious that, sometimes it's very, very obvious that you've already kind of split the ALL, you'll see a big fish mouth gap. You'll be hitting these 15, 20-degree trials in very easily. You're almost certainly through the ALL there, okay? Sometimes you're not. So if you're not through the ALL, you don't want to keep going with the trials, because then you're going to bust your end plates and get subsidence and whatnot, and kind of defeat the purpose of what you're there for. So what I'll do at this point in time is I'll I'll loosen the retractor, I'll migrate it anteriorly, okay? Usually you can kind of see where the front of the disc space is diving into the retroperitoneum. I'll take a Penfield 4 instrument. You see the disc space. You take a Penfield 4 instrument. You just carefully sort of dissect along the ALL. And I'll use a lot of AP fluoroscopy at this point in time to make sure that I'm at least halfway. There's actually a study by Pimenta, I didn't include it here. You can do measurements on your preoperative MRI to make sure that the amount of areolar space between your spine and your vessels is, at least a few millimeters safe. Whereas you want to proceed very, very cautiously, or not at all, if the vessel looks stuck to the front of the spine, right? But very, very carefully, I'll dissect in front of the ALL with the Penfield 4. Once that path is created, I'll use the ALL retractor that has the little divot cut in front of it, pass that along to about halfway in front of the ALL. And along that divot, I'll pass a blade to cut the ALL. Then once you've cut the ALL halfway, you do not need to go all the way. I would not go all the way to the other side. Just halfway is fine. Stay away from blood vessels, right? And then once you've done that, you can put in that jack that I showed, and then split. And again, you'll twist, you'll get some resistance, and then you'll almost always hear a snap and then feel a give. And then your ALL is through, especially with on your fluoroscopy, you see that your jack's completely wide open. That's how I do it, and that's how I would do it. Once you've done a couple, it's actually pretty straightforward, but understandably, the first couple can be very scary.
Thank you. Two related questions. First, with respect to the ALL dissection, do you dissect just over the disc space, or how much space upwards and downwards do you dissect around the disc space?
Just in front of the disc space. You just need that thing cut halfway, and then it's going to go for you. So you don't need to dissect above and below along the bodies. You just need you're going to see the gap of your discectomy from your regular disc prep, and then you're just going to dissect right in front of that. I think that's really all you need.
Thank you. Next question. With respect to the ACR retractor, for many surgeons around the world that do not have access to the latest retractors, we may not have a specialized ACR retractor. What kind of retractor would you recommend to do this surgery for the ACR?
Actually, the retractor is the exact same as the lateral retractor. It's not a separate retractor. I would say if you don't have access to the lateral retractor, it's going to be a little hard to do this for a couple of reasons. One, the retractors have sort of built-in light handles, which just allow for illumination and good visualization. The other thing is that the retractors allow you to toe the blades. And so sometimes that can be really, really useful. For example, at L4-5 and you're bumping into the crest, or higher at L1-2 or L2-3 and you're bumping into a rib. Having the ability to toe the blades is pretty important. That being said, to do an ACR is not a different retractor to do a regular lateral interbody surgery. So it's the exact same retractor.
Thank you. With respect to the position, what differences have you found between doing the ACR in a lateral versus a prone position?
Oh, I have not done ACR in the prone position. I don't think that I will. I think just because of the proximity of the vessels and the visualization that's important to have that dissection, I'll probably continue to do those in the lateral position. Now, with regular prone surgery, I think it's very, very similar. Sorry, with prone lateral surgery, I think it's very similar to lateral surgery. You just have to get used to the frame shift in your mind with, with the fluoroscopy machine. Your shoulders will get a little tired from, operating with your hands out front. I'm not very tall, so I just sit and do a prone lateral surgery. I think some taller people, stand and angle the bed in certain ways, but I just sit and I just try to keep the patient in a very neutral position so that my instruments work in planes, perpendicular or parallel to the ground and to the walls.
Great. The next question is, what recommendations or what things do you take into account? And this is a very common problem with lateral surgery with respect to lowering subsidence, both in ACR and non-ACR cases.
Great question. So I think two things. One, like we've talked about, just preoperative optimization, making sure that patient's bone quality is reasonable. And I don't get a DEXA scan on everybody. I get a DEXA scan very, very rarely, in fact. I think you can get a gestalt from the patient's x-rays and even from their CT scan. You can measure Hounsfield units to get a good sense of their bone quality. Usually a DEXA scan is to confirm a diagnosis of osteoporosis and then to get the patient treated. I think it's very, very important to not violate the end plates when you're doing your disc prep. I think the instruments kind of most likely to do that are probably the angled cobs or the angled curettes. So just being careful with those and not violating end plates. I think probably the most important is just getting a good feel for the size of interbody graft that you need. So yes, you rely on fluoroscopy, but also, I think some people really want to hit in the biggest cage possible. They're hitting in 12 or 14 millimeter cages. I think that's pretty big. And I certainly think that there's more studies that show that the more you over distract patients, the more likely they are to subside, right? So really, it's kind of just the trial that's, snug but not too tight is the trial that you want. Now, when it comes to ACR, you've essentially disconnected the spine. So you do get some tactile feedback, but you also lose some of it, right? So that's going to be feel as well. Also, how much correction you're aiming for, and we've learned that the greater the height, the greater the correction. So a lot of it is just based on feel and based on visualization when it comes to ACR and subsidence. I don't think I've seen subsidence with ACR surgery yet. But I think a lot of that just has to do with selecting good patients for it.
Thank you. The next is also a technical question. For all lateral surgeons, the technique changes with time as you become more and more proficient with it. One of the things that are usually taught to many lateral spine surgeries, especially at the beginning, is the use of the pins on the retractors. As you evolve, as you tend to do more cases, the use of pins tends to be less and less. For those surgeons that are starting in lateral surgery, What would you recommend with respect to pin use, both in the transpsoas and the antipsoas approach? And specifically, if you are more advanced and you want to consider doing an ACR, what would be your recommendation with respect to pins and chims?
Great. That's a great question. I think there's definitely been some cases early in my practice where I wish I had used shims, right? I can tell you I don't use them. I think that I like to have the maneuverability of the retractor, even for lateral surgery. Sometimes for example, I did a 2-level lateral today. The neuromonitoring was pretty strong at the posterior aspect of the disc space. So I docked anteriorly, and I really liked having the ability to just sort of migrate the retractor posteriorly with the once the retractor blades were open. I think early on, having a shim is good, just to get confidence in how everything looks with the disc space, and to make sure that your retractor doesn't migrate, which it can do if you don't have a sturdy retractor. I think with more and more experience, you know how things are supposed to look. And so I think the use of the shim becomes less important. I think for ACR surgery, it's very reasonable to use a shim at first, although you'll have to remove the shim later in order to migrate your retractor anteriorly, at least the way that I do it. So I can't say that I've used the shim, but I could certainly see how it might be useful, especially if you're getting started.
Thank you. The next question is, what are your recommendations for lateral osteophyte management in lateral surgery?
Great question. So, I think sometimes these patients with severe disc degeneration, they develop these lateral osteophytes, right? So there's 2 ways to go about it. If it's part of your lateral surgery, your 2 options are, 1, go on the side where the osteophyte is not and break through it, with your cob or your instruments. The other option is to tackle it. And that's what I usually do. So usually the osteophytes develop on the concavity of the patient's curve. So I'll dock right on the disc space. Sometimes, you can't, sometimes you'll find a little sliver where sometimes the osteophytic bone is weaker, so you are able to get the K-wire in. Sometimes you're not, in which case I'll just dock my retractor there. I'll confirm with X-ray that we're over that level. I'll open the retractor blades, I'll dissect, and then I'll just bite it down or drill the osteophyte away to get to the regular disc. And that's how I usually manage it, either biting it down or drilling it.
Have you ever had any problems with anterior osteophytes for ACR?
For ACR, once. That's a great question. You can get the anterior osteophytes. That's going to be very dangerous for a couple of reasons. Usually, when you do have those anterior osteophytes, I find that those patients are where the vessels become very, very stuck to the front. So you're just going to want to be very, very meticulous with your dissection. I've a couple of times when I've felt very, very safe with the plane, I've attacked those osteophytes with an osteotome. That's not something I would recommend until you become more experienced with ACR, obviously, because osteotome is very sharp and very dangerous. But that's how I've tackled it then. So again, very patiently. So I start posterior, very, very slowly inch anterior with the osteotome. I'll check with the jack frequently to see if I can spread. If I can't spread, then I'll inch a little further with the osteotome. I keep basically trying to weaken the osteophytes anteriorly until I'm able to get the spread with that spreading device.
Thank you.
I find that osteotome is probably the best instrument for that.
Thank you. One last question is with respect to vascular management. Have you ever had a vascular injury in the ACR? And what recommendations would you give all surgeons for the avoidance and management in such a case?
You bet. So great question. I'm always one very happy, well, maybe not happy, very willing to talk about my complications. And I find that lateral interbody surgery, when it goes really, really well, it's like so smooth and so perfect. But I've certainly had bowel injury, like I've mentioned. I've had one vascular injury. I've had a patient come back with an incisional hernia. I've had, femoral nerve, a quadriceps weakness after this. So these are all things to think about, and to not take lightly. I've not had vascular injury with ACR. I've had one vascular injury with a regular lateral. I think the important things are to, one, really, really study the vascular anatomy on your preoperative imaging. So you want the vessels, both the aorta and the IVC, to be in front of the disc space. And if there's any level where that vein, usually it's the vein, that crosses over the disc space, you either want to approach it from the other side, okay, and not be too aggressive with your instruments, right? I talked about the importance of releasing the contralateral annulus. You don't want to do that if there's a vessel on the other side. So you want to just get right to the edge there. If your goal is fusion, just big enough to get an inner body in, and not go through the annulus if there's a vessel waiting there on the other side for you. If you do get a vascular injury, at least I don't have the know-how to fix that on my own, okay? So the key step is to pack, all right? And sometimes if it's a little vein, if you pack it, you wait for several minutes, it'll sort of, take care of itself. If it's a major vessel though, like aorta or, IVC or whatever, that's not going to stop on its own. So you're going to want to call your vascular surgeon. And it's a very, very harrowing experience because an incision like this becomes an incision that wraps all the way to the front of the belly. But they're going to be the ones who kind of get that exposure and fix that vascular injury for you.
Thank you. Well, Dr. Coy, thank you very much for such an enlightening lecture. I think we have grown as surgeons with all the experience that you have shared with us. On behalf of CIEN and the IWBNC, I would like to thank you again for this opportunity for sharing your knowledge with us and your experience. To all our participants, remember that you can, through the chat, have access to the other lecture that is right now ongoing with Dr. Rokuya Tanikawa, microsurgery with precise anatomy for cerebrovascular and skull-based lesions. Please remember, this lecture is available and will be available 24 hours on CNU's page for your review later. So Dr. Coy, thank you very much for being with us, and have a good day.
Thank you, Dr. Torres. It's been a great experience, and I look forward to meeting you in person sometime soon, hopefully.
Likewise.